Welcome to this program on innovations in retinal vascular diseases, enhancing patient outcomes through long-acting therapies and precision dosing. I'm Peter Campochiaro, and I'm joined by my esteemed colleague, Dr. Diana Do. Thank you to PeerView for providing this session, and thank you to Regeneron Pharmaceuticals for providing the educational grant. Please respond to polls as they appear on your screen, and enter questions in the chat, which will be answered in the question and answer session. Visit the PeerView website to view the slides and to see the practice aids. This slide lists the goals for the presentation today. Now, retinal vascular diseases are leading causes of vision loss in older adults and in patients with diabetes. And there are a number of needs for treating these patients, including healthcare disparities, breakdown in referral and continuity of care, challenges with the first generation VEGF antagonists, which often require frequent injections, which can be a burden for patients, resulting in difficulty with coming in as frequently as needed, which can result in poor outcomes. And then lack of awareness of mechanisms and approaches for using the novel agents. Now, I'm going to briefly discuss pathophysiology and treatment of the retinal vascular diseases. Now, the basic underlying problem in neovascular AMD, diabetic retinopathy, and retinal vein occlusion is hypoxia in the retina, which results in upregulation of a number of hypoxia-regulated vasoactive substances. Now, despite the fact, it's remarkable that despite the fact that there's multiple agents that are upregulated, this inhibition of VEGF has substantial improvement in much of these conditions. And the way that VEGF acts is it binds to VEGF receptors, which causes signaling that results in stimulation of neovascularization, vascular leakage, and inflammation. And VEGF antagonists, such as bevacizumab, ranibizumab, aflibercept, and faricimab, bind to VEGF, prevent binding to VEGF receptors, which decreases the signaling and decreases neovascularization, vascular leakage, and inflammation. Now, aflibercept also binds placental growth factor, which plays a small contributing role. And faricimab also binds angiopoietin 2, which is an antagonist for Tie2, which is another receptor. And because it's an antagonist, decreasing the levels of angiopoietin 2 results in stimulation of Tie2, and that causes vascular stabilization and reduced responsiveness to VEGF-A. So that combined binding of VEGF and angiopoietin 2 has a synergistic response. Now, blocking VEGF demonstrated substantial improvements in neovascular AMD, proliferative diabetic retinopathy, diabetic macular edema, and retinal vein occlusion. And that was first translated into clinical practice in 2006 when ranibizumab was approved for neovascular AMD. This arrow shows the timeline of approval of other agents. Now, despite the very good outcomes in clinical trials, outcomes in clinical practice have been disappointing. And that's largely due to undertreatment because of the high burden from frequent visits and injections, the heterogeneous response in different patients, and in some cases, the financial burden. Now, this slide shows the indications for currently FDA-approved agents. All of them are approved for neovascular AMD and diabetic macular edema, and all but faricimab are approved for diabetic retinopathy. aflibercept, 2 milligrams and 8 milligrams, faricimab and ranibizumab are approved for retinal vein occlusion. And ranibizumab is approved for myopic CNV, and 2 milligrams of aflibercept is approved for ROP. Now, bevacizumab is often used off-label for these indications. Now, all of these agents are delivered by intravitreal injection, but ranibizumab can also be delivered continuously from the port delivery system. Now, among these different agents, 3 second-generation approaches have potential advantages. 8 milligrams versus 2 milligrams of aflibercept results in prolonged therapeutic levels in the eye, which in some patients can result in longer intervals in between treatments. And as I mentioned, inhibition of angiopoietin 2 as well as VEGF-A results in vascular stabilization and decreased action of VEGF-A, resulting in this synergistic effect, so that faricimab can also decrease the interval or increase the interval between injections in some patients. And then the port delivery system, which provides continuous delivery of ranibizumab with refills every 24 months, can markedly reduce the need for coming in so frequently. Now, here's a question for you to answer. Which of the following accurately reflects the mechanism by which each of these therapies offers options for extended interval dosing? Aflibercept 8 milligrams is formulated with a protein to provide slower rate of excretion. Faricimab has a dual mechanism of action inhibiting VEGF-A and placental growth factor. Ranibizumab is offered in a port delivery system that can be refilled at longer intervals. All of these are correct, or I'm not sure. Okay, now my esteemed colleague, Diana Do, who's the Vice Chair of Clinical Affairs, a Professor of Ophthalmology at the Byers Eye Institute at Stanford University, will now present innovations in longer-acting anti-VEGF treatment for neovascular AMD.
Thank you, Peter. Thank you for setting the stage and giving everyone a reminder about the pathophysiology. Now it's my pleasure to talk about longer-acting anti-VEGF treatments for neovascular AMD. We know that neovascular AMD is a big public health issue. There are 20 million people in the United States who have AMD and 196 million globally who may be affected by the neovascular form. We recognize that this is the leading cause of severe vision loss in older adults if neovascular AMD is not properly treated. And there are multiple risk factors for why one patient might develop the neovascular form. There are genetic risk factors, there's environmental risk factors such as smoking, and other things such as body mass index and race. When we look at the American Academy of Ophthalmology and their preferred practice patterns, if there was an article in 2024 that reminded us early detection and treatment of neovascular AMD are essential in improving vision outcomes. In addition, the first-line treatment for neovascular AMD is the administration of intravitreal VEGF inhibitors. And we know that adequate treatment and dosing of VEGF inhibitors is essential to improving and maintaining vision outcomes. And finally, when we're treating patients with intravitreal VEGF inhibitors, we know that monitoring of symptoms afterwards is also essential because there are rare side effects such as endophthalmitis, and prompt treatment of any adverse events is important to saving vision. Let's look at some of the key phase 3 clinical trial data that led to the approval of aflibercept 8 milligrams. The pivotal trial was the PULSAR phase 3 study, and it looked at aflibercept 8 milligrams compared to aflibercept 2 milligrams. And the key aspect of this clinical trial was that aflibercept 8 milligrams was dosed every 12 or every 16 weeks and compared to aflibercept 2 milligrams dosed every 8 weeks. And we can see that aflibercept 8 milligrams was found to be non-inferior in visual acuity outcomes, but also the key finding was this was achieved with these dosing intervals of 12 weeks or 16 weeks. Peter, I want to ask you, what are your thoughts about the Pulsar study? And specifically, when we look at the extension study, we see that these vision outcomes are maintained with these longer dosing intervals. Did this affect how you want to use aflibercept 8 milligrams in clinical practice?
Yeah, I think it has, Diana. There's many patients who it's difficult to extend beyond 4 to 6 weeks, and that can be very difficult for them to come in that frequently. So having this longer acting agent can really help in the management of such patients, allowing extension so that they can come in much less frequently and still get similar outcomes.
Yes, I agree with you because we see these vision curves on the screen left. On the right, we look at the OCT mean central retinal thickness and whether patients were treated with aflibercept 8 milligrams or 2 milligrams, we see this rapid reduction in retinal edema. And the key finding here is that with aflibercept 8 milligrams, we can have longer intervals, but yet still have disease control. In fact, 80% of patients on aflibercept 8 milligrams maintained intervals of 12 weeks or greater between treatment. You mentioned earlier about faricimab. This is the first bispecific that inhibits both VEGF-A and angiopoietin-2. And the phase 3 clinical trials, TENAYA and LUCERNE, evaluated faricimab compared to aflibercept 2 milligrams. And it led to the approval of faricimab because it met its primary endpoint in that faricimab was non-inferior in visual acuity outcomes to aflibercept 2 milligrams. But the key finding for this study was also durability, the ability to maintain equal vision, but yet dose patients on faricimab every 16 weeks or every 12 weeks. And Peter, when you look at the faricimab data compared to the aflibercept 8 milligram data, both are very efficacious. How do you choose between these two agents? Both are outstanding in their efficacy.
Yeah, I think that in many ways they're quite similar. So we individualize in patients and often see how they respond to the 2 milligram of aflibercept. And if they're quite responsive to VEGF suppression alone, then you're more inclined to go to the 8 milligrams of aflibercept. But if you're really having difficulty eliminating fluid, you might want to think of using that agent that blocks both VEGF and angiopoietin-2.
Yes, I agree with you. And we can see here that both the vision curves and the OCT curves, and we see the effect through 112 weeks, showing that faricimab, even though it's dosed less frequently than aflibercept 2 milligrams, has the durability, the efficacy, and also the drying effect. When we look more specifically at the OCT and the drying effect of faricimab, we can see that there seems to be a slight suggestion that faricimab may be, in some patients, better at reducing the retinal thickness. And we can see with that curve, that matched dosing phase from baseline to week 12, there is a slight advantage with faricimab. Does this early matched phase curve change your perception of using faricimab in those patients who have more edema or who have more difficulty with getting their disease under control, Peter?
Yeah, it certainly does, Diane. I think that we know that persistent fluid can have deleterious effects on visual outcomes over time. So even though in this relatively short clinical trial, there wasn't a major advantage seen in visual outcomes, you can think that over the long term, it may be useful to have better drying in the retina.
Yes, I agree with you. I think that's why a lot of patients who have excess fluid and are harder to treat, we do try to adjust agents and consider faricimab because it inhibits both VEGF-A and angiopoietin 2. When we look at these new agents, besides efficacy, we also evaluate safety. And when we look at the safety data for faricimab, there were no new safety signals, no cases of occlusive retinal vasculitis, and the safety profile remained quite excellent. In addition, when we look back at aflibercept 8 milligrams, there also were no new safety signals, and the safety profile appeared to be equivalent to that of aflibercept 2 milligrams. Besides looking at the pivotal clinical trials, let's look at some real world evidence and see how retina specialists are using faricimab in clinical practice. To do so, we look at the far retina and far wide clinical studies, which were looking at big data retrospective databases, and looked how retina specialists were using faricimab to treat neovascular AMD. And they looked at two populations, treatment naive patients and previously treated patients. And what this study found was that when we started patients who are treatment naive with faricimab, patients were able to gain some vision, were able to see a reduction in their retinal thickness, and there were no safety signals. In addition, when we look at previously treated patients who had received other anti-VEGF agents, when they were switched to faricimab, these patients were able to keep their vision stable, but they were able to have an additional, perhaps, reduction in their retinal thickness, suggesting that there was some benefit to switching. Peter, when we first have new agents on the market, are you using them in both treatment naive patients and previously treated eyes, or do you prefer to test them in one patient population first?
Well, Diana, we're often constrained by third-party payers, and so it's often mandated that we use some of the first-generation agents, and then only in patients who have suboptimal outcomes go to the newer agents. And that's commonly how I do this. And there are many patients who do quite well on 2 milligrams of aflibercept, but those that have difficulty eliminating all the fluid or not being able to extend, longer than 8 weeks, it's very useful to consider some of these longer acting agents.
I agree with you. And I think we are sometimes constrained by the insurance carriers. And if we didn't have those constraints, we may want to use these new second generation agents from the get-go. Another study that looked at real world evidence was the Truckee study. And these patients had received prior anti-VEGF agents and then were switched to faricimab because they still had active neovascular AMD. And in this retrospective study that included multiple clinical practices, they saw that there was a benefit to switching to faricimab, and there was a significant reduction in central retinal thickness. And the authors suggested that there is a benefit in those difficult to treat patients that we discussed earlier. Now let's look at the Archway study, which looked at the port delivery system and a special formulation of ranibizumab. In this specific study, we have 5 years of follow-up in patients who have neovascular AMD, and they received the port delivery system implant. And what the data shows is actually their vision remained exquisitely stable through these 5 years of active treatment, and their retinal thickness also remained under control with the port delivery system. Peter, this data is very efficacious, showing true durability. Do you use the port delivery system in clinical practice, and who do you recommend it for?
Yeah, I use it, Diana, and I've found, just as you mentioned, it has remarkable efficacy. I mean, when you compare this to some of the observational trials that have looked at the outcomes in clinical practice, this is just so much better. So I tend to use it in patients who have, difficulty extending, and are really not tolerating coming in every 4 to 6 weeks and having frequent injections. And I find that the patients that have had it really like it. The patient approval for this is just remarkable.
I think it is a great treatment option in our armamentarium, and I'm surprised more retina specialists aren't utilizing it yet. And certainly, there is a new and improved version of the port delivery system that has been available over the past year after they corrected some of the safety issues with it. Now let's discuss a clinical case that could be easily seen in our clinic tomorrow, or many of the clinic that our audience members have as well. So this is a 72-year-old woman who is following up for neovascular AMD. She has previously received bevacizumab, but she's having trouble coming back for frequent visits. She lives in a rural setting. Her visual acuity is 2400 in the right eye and 20/25 in the left eye. There is some subretinal fibrosis in the right eye, and in the left eye, she has subretinal hemorrhage and macular thickening. This is the left eye, which is her only good eye. We see the hemorrhage, the lipid, the thickening on OCT. My question for our audience is, when you're considering this case, what would inform your next step and recommendation? The options are: one, all anti-VEGF agents significantly restore vision in all patients. Two, anti-VEGF options can delay vision loss, but don't address the damage in the eye. Three, extended interval dosing options have similar efficacy to traditional monthly dosing. Four, extended interval dosing options are convenient, but not as effective as monthly dosing. Or five, I'm not sure yet about what to do in this case. Please take a moment to answer this question. Peter, this is a challenging case. I guess what would you recommend for her good left eye?
Yeah, you're right, Diana. This is challenging, because the patient has only one good seeing eye, and that eye, seems to be in a bit of trouble. There's a subretinal hemorrhage. There's a fairly large PED, and there's intraretinal fluid overlying that. So her current treatment really is not doing what we want it to do, although her vision right now is quite good. But in order to keep that vision good, I think we want to be more aggressive in her treatment. So I think, moving to another agent, I think would be very good. And this is one where I think you want to be a little bit cautious in terms of your extension. I think I would start with one of the longer acting agents, but maybe using it quite frequently, monthly at first, and then see if we can get resolution of the hemorrhage, resolution of the fluid, and then gradually extend the period between injections. What do you think, Diana?
Yes, I agree with you. I think I would definitely consider either aflibercept 8 milligrams or faricimab in this patient. And as you recommended, going very cautiously with extension because she is monocular. And I think now with the ELARA study, aflibercept 8 milligrams is approved for as often as every 4-week administration. So if one chooses that, you could give it monthly until you had a really good response and then slowly extend by 2 or 3 week intervals. We discussed that there are these challenges with this monocular patient. We don't want to extend so quickly by a month or 2 months because she only has one good seeing eye. And I think, using either faricimab or aflibercept 8 milligrams are great options for any patient who has neovascular AMD. Peter, I'm going to hand it over to you for this next section on diabetic macular edema and diabetic retinopathy.
Thanks, Diana. So retinopathy is very prevalent in patients with diabetes, occurring in, up to 28.5% of patients who are 40 years or older. And macular edema is also very prevalent, occurring in about 13.6%. But diabetes affects multiple organs in addition to the eye. So, in addition to eye problems, patients may have damage to their kidneys, peripheral neuropathy, and have an increased risk of coronary artery disease and stroke. So it's very important to coordinate with other providers when managing your patients with diabetic retinopathy. Now, only 60% of diabetics get the recommended screening for diabetic retinopathy. And that's really unfortunate because early treatment is particularly beneficial. The anti-VEGF agents are much more effective when you're treating early in the disease. And they can be particularly effective in terms of treating center-involved diabetic macular edema, reducing the severity of diabetic retinopathy, and effectively treating proliferative diabetic retinopathy. And, the major concern, as Diana mentioned, is endophthalmitis. But with use of topical povidone iodine, the incidence of endophthalmitis is reduced to about 0.4% per injection. Now, the PHOTON study examined the 8 milligrams of aflibercept in patients with DME, just as the PULSAR study did in neovascular AMD. So this is in diabetic macular edema. And just as in that study, aflibercept 2 milligrams was compared to 8 milligrams of aflibercept either every 12 weeks or 16 weeks. And the efficacy was essentially the same with the longer duration between or longer interval between treatments with the 8 milligram compared to 2 milligrams of aflibercept every 8 weeks. Now, this slide shows sort of the pooled 8 milligram group, and you can see that things were similar at the primary outcome at 48 weeks. And then both the 2 milligram group and the pooled 8 milligram group maintained vision very well out to 96 weeks. And the number of injections with the 2 milligrams of aflibercept out to 96 weeks, the mean was 13.8 versus 8.9 in the pooled 8 milligram group. Now, at 96 weeks, the patients in the 2 milligram aflibercept group were switched over to 8 milligrams of aflibercept with extended dosing. And with that extended dosing, they continued to maintain very good vision. So what this demonstrates is that treatment with either 2 milligrams of aflibercept every 8 weeks or, much less frequent 8 milligrams of aflibercept has similar efficacy. Diana, what do you think of this in comparison to treatment with neovascular AMD?
I think it's reassuring that the diabetic macular edema data is very similar in that it's efficacious, the durability of extending the interval between treatments is also there. So it wasn't surprising because aflibercept 8 milligrams gives 4 times the molar dose of aflibercept 2 milligrams. And when something works well in neovascular AMD, I'm not surprised it's going to work equally well in diabetic macular edema.
Yeah, and as you mentioned in neovascular AMD, the majority of patients were able to maintain that extended treatment. Now, 10% did have to fall back and have, more frequent treatment, but the vast majority are able to continue with that extended dosing. Now, Yosemite and Rhine investigated faricimab in diabetic macular edema, and it compared 2 milligrams of aflibercept every 8 weeks to faricimab, 6 milligrams every 8 weeks, or with a personalized treatment interval of 6 milligrams of faricimab, which was extended out to up to 16 weeks. And you can see that with all of these treatment groups, there was robust improvement in visual acuity that was maintained. So very similar efficacy to the faricimab with extended dosing compared to aflibercept every 8 weeks. Now, Diana, as you pointed out, in neovascular AMD, there appeared to be a better drying effect with faricimab compared to aflibercept. And that was similar in diabetic macular edema. As you can see, there was greater reduction in central retinal thickening with the faricimab groups. And what do you think of that sawtoothing that you see with the aflibercept?
Yes, I think this curve looking at the retinal thickness is very informative. We do see that sawtooth pattern with aflibercept 2 milligrams because when it's dosed every 8 weeks, there are these natural fluctuations when there's not enough inhibition of the active VEGF in the eye. With faricimab now, we have the higher molar dose of the VEGF inhibitor because that's 6 milligrams. And also we have the inhibition of angiopoietin 2. And maybe that dual effect from this bispecific allows faricimab to have that greater drying effect.
Yeah, I agree, Diana. Now, the Pagoda trial tested the port delivery system with refill exchanges every 6 months and compared it to monthly injection of ranibizumab in patients with diabetic macular edema. And you can see from this curve that when the PDS was implanted, there was a small reduction in vision, this 5-letter decrease, which recovered fairly quickly. And at the primary endpoint, the visual improvement was the same with the port delivery system or monthly injections of ranibizumab. So this showed non-inferiority, and the port delivery system was approved for diabetic macular edema as it was for neovascular AMD. Now, after the primary endpoint, the patients who were in the monthly injection group got the port delivery system implanted. And once again, those patients showed a small decrease in visual acuity that was transient. It then recovered, and then both groups maintained excellent vision out through 4 years. So, Diana, what do you think of these sorts of data for patients with macular edema?
I think this data is very convincing, showing that the port delivery system truly does allow for sustained control of diabetic macular edema, similar to what we saw with the neovascular AMD in the port delivery system. And I think that, retina specialists need to consider it as an option, especially in those patients who have recurrent diabetic macular edema, poor control of the diabetic retinopathy. The port delivery system certainly would help control their disease for many, many years.
Yeah, and as retina specialists, we're accustomed to looking at OCTs. So it's useful to look at some of the OCTs from these Pagoda patients. Now, this is a patient who was in the PDS group and had very severe macular edema at screening. And during the run-in phase, there was a small amount of improvement, but there still was severe edema at the time that the PDS implant was done at 16 weeks. Now, each of these circles represent a refill exchange, and this patient had 5 of them. And you can see that there were still large cystoid spaces that gradually decreased and eventually resolved. And at the last follow-up at week 169, there was no edema with 20/20 vision. So what this demonstrates is that, in patients with severe edema, there's good benefit to sustained suppression of VEGF. Now, this is a patient, Diana, who, if we were treating it in clinical practice and giving intravitreal injections, here at a year after starting treatment, many people would say this patient is just unresponsive to VEGF-A suppression. But you can see with sustained constant delivery of this VEGF antagonist, gradually the edema resolves. So what do you think of, patients who have really severe edema in this approach?
This is a great case because it shows that, a lot of times when we think a patient is non-responsive to a anti-VEGF agent, we're not giving the patient a long enough course of the VEGF inhibitor. And with the port delivery system, we're seeing that with continued VEGF inhibition, we are eventually getting that beneficial effect. So I think it's rare for a patient not to respond to a VEGF inhibitor. We're just not treating them adequately enough in clinical practice.
Great points, Diana. Now, here's another PDS patient who had really severe retinopathy at baseline, and vision was 2100. Then 112 weeks after PDS implantation, you can see that the retinopathy is completely resolved. The patient had 20/20 vision. Now, the Pavilion trial investigated the PDS and compared it to observation. And in this case, refill exchanges were only done every 9 months. These were patients who had either moderately severe or very severe diabetic retinopathy. You can see that in the PDS group, which is shown here in the dark line, that 80% of them at 1 year had at least 2-step improvement in diabetic retinopathy severity score, compared to only 9% in the observation group. But even more importantly, Diana, the port delivery system essentially eliminated vision-threatening complications. At 1 year, only 1% of patients in the PDS group had a vision-threatening complication, compared to 47% in the observation group. And those benefits, both in terms of vision-threatening complications and development of center-involved macular edema, were sustained through 100 weeks, which is shown here on the left in this slide. Now, at 100 weeks, 29 patients who were previously in the observation group got PDS implantation. And after PDS implantation, in this subgroup of patients, the vision-threatening complication, the percentage who had vision-threatening complication, decreased from 20% to 0. So, what do you think in terms of, the fact that many patients in clinical practice, when you treat them with anti-VEGF agents, you're always concerned about them coming back. But if you have a more reliable treatment that really reduces vision-threatening complications, how do you think that helps us in our management, Diana?
I think this is very convincing data. We know that the patients who have severe non-proliferative diabetic retinopathy are at very high risk. We usually say about half of them will progress to proliferative disease within 1 year, or we see that they develop a lot of these vision-threatening complications, such as diabetic macular edema. And if we're only occasionally observing them or treating them with, quarterly anti-VEGF injections, we're going to have a lot of patients who are going to break through and develop these vision threatening complications. The port delivery system certainly shows us that with continued sustained delivery of a VEGF inhibitor, we're going to eliminate a lot of those complications. So this should be considered for these patients.
Thanks, Diana. And the one of the likely reason for this almost complete elimination of vision-threatening complications, which are proliferative diabetic retinopathy or anterior segment neovascularization, is that in the observation group, you can see that there's progression of retinal non-perfusion over the course of a year, both centrally, here shown on the left in the macula, and peripherally in the 7 ETDRS fields. But the darker line, which is the PDS group, you can see that there's essentially no progression of retinal non-perfusion. So that's a likely explanation for why these patients essentially don't get vision-threatening complications. Now, Diana, as you mentioned previously, one of the concerns about the PDS is the risk of endophthalmitis. And initially, prior to June of 2020, the cumulative risk of endophthalmitis was 2.6% in patients this is all patients who had PDS implantation. And a lot of that was due to the fact that some investigators were not paying really good attention to the closure of the conjunctiva and Tenon's capsule. But in June of 2020, there was a lot of investigator education that went on, explaining good techniques for closure of the conjunctiva and tenons, as well as other factors related in the implantation technique. And then after June of 2020, with use of these improved approaches, what was found that over the next 2.45 years, the cumulative incidence of endophthalmitis decreased to 1.1%. And you can see here on the right that that was associated with elimination of endophthalmitis related to conjunctival retraction. Now, it's important to remember that 1.1% is a cumulative incidence of endophthalmitis over 2.45 years. Now, we're used to thinking, Diana, in terms of the incidence of endophthalmitis per procedure. And if you think of that 0.04% incidence of endophthalmitis with each injection that we give, when we give a lot of injections, then that cumulative incidence goes up. And if you look at the calculation of using 0.04% per injection, if a patient receives 8 injections per year for 2.45 years, that results in a cumulative rate of endophthalmitis of 1.1%, which is the same as what you get with the PDS. So I think that you asked, Diana, why aren't a lot of retina specialists using the PDS more? I think maybe it's partly because of this misunderstanding that the longer you go with the PDS, the cumulative rate of endophthalmitis goes down, whereas with injections, it's going up. So I think once people understand that the endophthalmitis is not a great deal more over the long term with the PDS, I think there might be more uptake. What do you think?
I think this is great data and how you presented it to kind of equalize the safety data. And I think the proper surgical training is also essential because the port delivery system, it is an implant, and we want to make sure that there is proper coverage of the septum to prevent any organisms like bacteria from entering to reduce the risk of endophthalmitis. And it's great that you showed that a lot of these patients, when we do 10 or more injections a year, that cumulative risk of endophthalmitis actually increases because we are injecting them so often.
Exactly. So let's look at a case, Diana, of Frank, who's a 62-year-old patient with diabetes who's not very well controlled. You can see that his hemoglobin A1C is 10.5, and he presents with a visual acuity of 20/80 in the right eye and 20/50 in the left eye. And he's got moderately severe non-proliferative diabetic retinopathy in both eyes. Now here's his OCT, and we're just going to deal with the right eye because of, time constraints. But he's got 20/80 vision and pretty substantial edema in this eye. So what would you think in terms of treatment options for this patient, Diana?
Well, I think if there were no barriers, I definitely would want to start off with either aflibercept 8 milligrams or faricimab to try to get the edema under control right away.
I think that's a good approach. In this case, there was some barrier, but one of the things, I mean, many patients like this, oftentimes um, we have to start with bevacizumab. But as Protocol T showed, there are some advantages to aflibercept. In this case, the insurance company approved the 2 milligrams of aflibercept, so he got an injection of aflibercept, 2 milligrams, and 4 weeks after this injection, you can see that there's some improvement, but there's still a very large cystoid space and 20/60 vision. Patient received another injection of 2 milligrams and came back. There is, some improvement, Diana, but vision's 20/70. And Frank's not very happy. He says, I don't see that much improvement in vision, and it's really hard. It's hard on my family and me coming in every 4 weeks. I'm not really seeing the benefit. So, in this case, we can ask the audience now. When you're considering Frank's case now, what's the best step to improve his retinopathy-related complication? In this case, diabetic macular edema. Would you refer him back to his primary care team to improve his glycemic control? Would you switch to aflibercept 8 milligrams every 12 weeks? Or 3, switch to faricimab 6 milligrams every 12 weeks? Or switch to ranibizumab, the port delivery system, with refills scheduled every 48 weeks? Or 5, you're just not sure what to do in this case. So we'll give you just a little time to mark that down. Diana, what do you think? How would your approach be at this point?
I think I would either switch to aflibercept 8 or faricimab, but not extend right away to 12 weeks. I would switch, see what happens in a month, and then if there's a good improvement, start extending then. But you did convince me that I should be thinking about the port delivery system earlier, because this might be a patient who would respond really well. And then that burden of, not having to come back so frequently would also be attractive with the PDS.
I agree with you, Diana. They put refill exchanges every 48 weeks. Actually, if they had put 24 weeks, I think that would have been a very appropriate answer. But I agree with you. I think this is a good candidate for either aflibercept 8 milligrams, faricimab 6 milligrams, with starting off with very limited extension or no extension at first, and then going to extension or considering the port delivery system. Okay, Diana, now you can go ahead and review some of the evidence with retinal vein occlusion.
Thank you, Peter. We know that retinal vein occlusion is also a common cause of vision loss when these patients present with macular edema. Certainly, the first-line agent for macular edema associated with retinal vein occlusion is intravitreal anti-VEGF therapy. In addition, there have been studies that suggested that intravitreal corticosteroids can also be efficacious and safe in these eyes, but we do need to monitor for cataract progression and elevated intraocular pressure. Let's look at some of the new data that evaluated aflibercept 8 milligrams compared to aflibercept 2 milligrams in eyes with macular edema due to retinal vein occlusion. This was the Quasar phase 3 clinical trial, and there was no surprise that aflibercept 8 milligrams was non-inferior to aflibercept 2 milligrams. But the benefit here was that aflibercept 8 milligrams could be dosed less frequency. And we can see that they could be given every 8 weeks. And then later on in the study, it could be extended further. Peter, when we look at this now, are you using aflibercept 8 milligrams in retinal vein occlusion?
Yes, I am, Diana, because I find that there are some patients who really cannot be extended very much at all. And in many of those patients, I've been able to extend them out quite a bit more with the 8 milligrams of aflibercept.
I agree with you. When we look at the macular edema response to aflibercept 8 milligrams, in addition, we see that aflibercept 8 milligrams resulted in rapid improvements in edema with excellent control of the disease over time. Now, if we look at faricimab, we know that it has the bispecific, and it also showed benefit in retinal vein occlusion in the Balaton and Camino phase 3 clinical trials. This compared faricimab to aflibercept 2 milligrams, and we saw that faricimab was non-inferior, and it allowed for first fixed every 4-week dosing, but then after week 24, patients could be treated on a treat and extend dosing interval, showing that faricimab could be extended, yet still control the disease and still have an improvement in visual acuity. Let's look at a clinical case. This is a patient who had sudden painless loss of vision in the right eye. Visual acuity was 2400 in the symptomatic eye and 20/25 in the unaffected eye. When we look at the affected eye, we see that there is edema, retinal hemorrhages, obviously a retinal vein occlusion. And the question here for our audience is, how would you treat this patient? Would you start with aflibercept 8 milligrams every 4 weeks or try to extend the interval right away? Would you consider ranibizumab in the port delivery system? Or would you choose another anti-VEGF agent and then treat monthly for this patient? I guess, Peter, what would your recommendation be for a patient who had macular edema and a central retinal vein occlusion?
Yeah, unfortunately, Diana, the port delivery system isn't approved for vein occlusion, so that's not a good option. But I think that uh, again, if there were no constraints, I think it would be very reasonable to start with 8 milligram of aflibercept or faricimab. I found less barrier in using the faricimab in vein occlusion than the 8 milligram of aflibercept, and I'm usually able to switch to it in patients who are requiring frequent injections pretty quickly. And so I often do that. But I have found that some patients seem to respond a little bit better to the 8 milligram. And so I do a little bit of switching back and forth.
I agree with
This,
you.
this has
And
been
we
new
know that,
experience.
yes, and we know that vein occlusion, especially central retinal vein occlusion, has a high VEGF load. And I think that 8 milligrams of aflibercept with, 4 times the molar dose of 2 milligrams can help those patients because they are so VEGF driven, their disease. And so we discussed about this case and how VEGF plays a role in vein occlusion, especially in CRVO when those patients have that chronic recurrent macular edema. And these new agents, either faricimab or aflibercept 8 milligrams, can give the patient a better chance at the disease control.
Well,
And so
Diana,
now,
we've
yes.
got a lot of good questions in the chat. And one of the questions is, does VEGF treatment increase the risk of geographic atrophy? And I think that there has been a lot of concern about that, particularly because the CAT study showed some, the possibility of increased risk of GA with more frequent injections. But I think subsequent data has really demonstrated that GA is going to occur in some patients with neovascular AMD. It never occurs no matter how frequently you treat in diabetic macular edema. And it's just part of the disease process in neovascular AMD. And the treatment with anti-VEGFs probably has very little impact on that. What's been your experience with that?
I agree with you. I don't think we should be worrying about inducing macular atrophy. The bigger problem is undertreatment with our anti-VEGF agents.
Now, Diana, there's a question here about how important is the site of injection? Do you think it makes any difference whether you inject in the supratemporal quadrant or inferiorly?
I don't think the actual site is important. I think, the technique using the povidone iodine to reduce the risk of endophthalmitis, I think that's the more important step. So I think whatever is comfortable for the retina specialist is fine.
Yeah, I agree. Now, do you think that faricimab would still have benefits with fluid reduction if compared to 8 mg of aflibercept? I mean, that's an interesting question. That sort of study has not been done. What's your feeling on that?
Yes, I think, it'd be great to have that head-to-head comparison, but we don't have that data. Both have a higher molar dose of the VEGF inhibitor, 8 mg with aflibercept, 6 mg with faricimab. I think both are great at reducing edema. The question is that angiopoietin 2 inhibition going to give faricimab a little bit of extra edge in some eyes with edema?
Yeah, I think I agree with you. I think it can be different in different patients. And so that's why we sort of have to personalize the treatment. Now, have you had any success in appealing to insurance companies to use 8 mg of aflibercept or faricimab in treatment-naive patients?
It is challenging. I find that in my geographic area, we are using step therapy a lot, using off-label bevacizumab as the first-line agent, and then showing they've had a suboptimal response before we're allowed to use on-label 8 mg of aflibercept or faricimab.
Yeah, it's the same for us. We really don't have much latitude there. Now, Diana, how do you choose between a regular extended interval versus a flexible, uh, personalized treatment interval?
I think I tend to do a treat and extend, and it's more personalized for the patient because I don't want to extend too quickly and have disease activity that could impair the vision. So I usually extend by 2 to 3 week intervals, depending on how the patient has responded. How about
Yeah,
you?
I agree with you. Those clinical trials were designed, in certain ways that we don't really necessarily have to follow exactly in clinical practice. And I do the same as you. I like to, individualize for that patient and just extend and try to find the optimal period where, you don't have that recurrence of exudation. Okay, and how important are epiretinal membranes or vitreomacular traction in consideration in these patients, Diana?
I think, if a patient has diabetic macular edema, also has an epiretinal membrane, I'm going to try to aggressively treat the DME first. If after, many anti-VEGF injections, if there's really no good response, then I will, discuss with the patient the surgical option. But I don't want to rush into surgery quickly yet because I want to see if the edema can respond to the intravitreal anti-VEGF agent. How about you, Peter?
Yeah, I agree with you. I think we have time for one last question, Diana. Where do steroids fit in your treatment algorithm in these patients?
I think there still is a role for intravitreal steroids in patients who I've treated, let's say with diabetic macular edema, with a lot of intravitreal anti-VEGF agents such as aflibercept or faricimab. If they still have persistent edema, I might add the dexamethasone intravitreal implant to see if that anti-inflammatory effect helps. And then I will, continue to do a combination. by adding also the anti-VEGF as well. How about you, Peter?
Yeah, I do exactly the same. Well, that's been a great discussion, Diana. So why don't you take us home?
Thank you so much, Peter. Really enjoyed talking with you and discussing. And of course, to all of our audience participants, thank you for interacting with us, answering those questions on the polls. Please visit pureview.com retinal diseases 26 to claim CME credit and to access the activity materials. We have many more online activities coming up, and we look forward to seeing you at a future event. Thank you again, Peter, for joining me tonight.
And thank you, Diana.